Chapter 36, Patients with Special Needs, or Patients with Special Challenges. As you're probably aware, there are people today with more and more chronic diseases that live at home. Some of these patients depend on mechanical devices such as ventilators, intravenous pumps, and other devices. We'll talk about some of those in this lecture. Don't be distracted by the equipment. It can be kind of overwhelming. Use the caregiver and family as the expert. Trust me, they know the equipment. Remember, focus on the patient. Some of the disabilities that you'll encounter are what we call intellectual disabilities. Developmentally or developmental disability may result from insufficient development of the brain resulting in some level of dysfunction. And this includes hearing, vision, and other intellectual impairments. Those who suffer from this disability may have an inability to learn and socially adapt to what we would consider a normal developmental rate. So it's divided into various different groups or levels, let's say. The first being a slight impairment. Maybe they're slow to understand, they have a limited vocabulary, and perhaps we can think of somebody that fits this description. Maybe the person behaves immaturely compared to peers of their age. Remember, this can be caused by a variety of different things, not just certain syndromes, but it could be like seizure disorder, activities that happened when they were younger that has caused some stunting, if you will, of their development intellectually. As I mentioned earlier, rely on the patient and other family members for information, especially when we have patients who are severely disabled in this area. The patients and caregivers can be invaluable help. But keep in mind that the patient who has this disability is susceptible to the same disease processes, the same illnesses as every other person. A common disorder is the autism spectrum. Now, this comes in a variety of categories, dare I say, severities. And we probably know somebody who suffers from autism or some form of dysfunction in this area, or disorder, excuse me. Asperger's falls into this category and such. Some of them have severe behavioral problems. They're hard to control. They suffer from increased stimulation, and we'll talk about some of those in a few moments. Maybe they have repetitive motor activities. They do the same thing over and over and over again. Not that this is in any way true to life that tells you, but there has been a lot of research done and even some entertainment TV shows that have tried to explore and help people to understand this disorder. I have a dear friend whose son is a high-functioning autistic, and he is amazing. And you wouldn't know it if you didn't know that he had autism. As we mentioned, there's a wide variety of spectrum of this disability. Some are completely nonverbal. They require almost 100% care to function, and others are, like I said, you wouldn't know it. They go throughout life, but then they get into one like feedback loop. It's kind of how I describe it, and it just kind of they get into that and they can't get out of it, and they have to calm down, or they have to do whatever their technique is, or medication, or whatever it might be. Again, always rely on the family, the caregiver, is the best way to approach and take care of our patient who suffers from this. It seems that it affects males 5 times more than it does females. So keep that in mind. Another common disorder that we see that is considered intellectual is Down syndrome. And there's been a lot of study and a lot of research done on Down syndrome, and many patients who are afflicted with this or affected by this function very well in society. They can hold jobs, they get married, they have relationships, they do amazing. We just have to keep in mind that they do have limitations, and they do have some physical abnormalities, such as we've all seen somebody with Down syndrome. They have, enlarged, protruding tongues that are seem to be overly large for the size of their oropharynx and such. Which, because of that, it can also cause some other challenges when the patient gets injured because they have this large tongue, and it can occlude the airway pretty quickly. An alarming study that shows that 40% of people who suffer from Down syndrome may also have heart conditions, hearing and vision problems. And I'm not sure what the life expectancy is. It seemed to be, for a while, it was fairly young, but I knew a woman with Down syndrome who lived well into her 80s. So with good care and good family support, a person who suffers from this disorder doesn't have to be limited in what they can do or their abilities. Sometimes a person who suffers from Downs can have a seizure disorder, and because they have a larger proportional head, there are some challenges that could possibly cause some increased complications during trauma because of the, as it says, atlantoaxial joint, so the joint at the very top of the skull and the head can be unstable in about 15% of the patient, which you can imagine could cause some problems of trauma if they hit their head or they fall. It's kind of like a pediatric patient, not really, but in a similar way that they have a larger head for the in ratio to the size of their body, and could cause some trauma that we normally wouldn't expect in an adult patient. So how do we interact with people with intellectual limitations? Well, first of all, this slide here mentions that it can feel uncomfortable, and this is true. I think one of the greatest things that I did personally when I was in high school, I was a TA for a classroom of developmentally delayed students, and it gave me an ability, it forced me to learn how to interact with people who are different than we are intellectually, and it was such a great learning experience. I had no idea at that time. I mean, I kind of thought I wanted to be a firefighter and a paramedic, but really I had no idea that that was going to be where I wound up years later. And I look back at that experience and I think, wow, that was really helpful. So like with every patient that we see, we want to be calm. We want to be friendly. Always introduce ourselves, who we are. I like to say sometimes, hi, my name's Doug, and this is the band or whatever. But make sure that, and keeping in mind that some patients will interpret that 100% literally, and then they'll be like, oh, so who's the band? What instruments do you play? So rather than doing that, say, hi, my name is Doug, this is George, this is Ralph, this is, Fred. And that makes everybody feel more comfortable. Again, it's really important that when we are doing procedures on patients, that we tell them what we're doing, whether the patient has um, a developmental delayed intellectual challenge, or whether it's a person who doesn't have that. Everybody deserves to know what we're going to do to them, so make sure that we do that. Watch for signs of fear and soothe that anxiety. A lot of patients, a lot of people, when we show up, are nervous and uncomfortable. We show up, we're wearing a uniform, we represent some kind of authority figure, and, and more importantly, they don't know who we are. So make sure that we establish a good rapport with our patients, explain everything that we're going to do, and try our best to soothe them, their fear, put it at ease, and develop that trust. Some patients who suffer from intellectual problems got that disorder because of a traumatic brain injury. It might have been in a car crash, or they might have been, fallen or hit or had some kind of traumatic injury. So it's always good to find out what their baseline is and establish what is considered normal for that patient. There is a gentleman that I've seen a few times in our area in Kitsap who used to be a deputy sheriff, and I actually knew him before he suffered his brain injury. And today he has a significant traumatic injury, and it's kind of like, wow, it's almost like taking care of a different patient or a different person. So find out what their baseline is, find out where they're at, and then, just like all of our patients, explain what we're going to do to them. What are the procedures that we're going to do? We're going to check their blood pressure. It's going to squeeze their arm. Some people think it's uncomfortable. Maybe we don't have to tell them that, but reassure them, make them feel comfortable that we know what we're doing. Another group of patients that we're going to take care of, which can be challenging for us, are those who are visually impaired. Now, this comes in a variety of degrees. Some people are just, they have loss of peripheral vision. Maybe they can't see, in the center of their vision, but all they can see is on the outside. They can distinguish light from dark. They can see better during the daytime, but not at night. And we don't know that until we get there. So it's really important that when we're interacting with the patient, that we tell them who we are, let them know before we touch them, introduce our team members, have our team members also introduce themselves, verbally. Don't assume that because the person is deaf that they can't hear. So that's super important, that when we're talking to a person who is visually impaired, that they can't hear. It's super important that we talk to them just like we would talk to each other. Don't yell at them. Don't, get frustrated. Explain everything that we're doing. And keep in mind, it's really important that we all make contact with the person, or let them know that we're there, we're on scene, and what we are doing and what the other members of the team are doing. So if we're the patient care person, the tech, if you will, and we're the one asking the questions, but our teammates are going to be checking vital signs, or maybe checking blood sugar, that kind of stuff. It's important that we don't just rush the patient, but we tell them and explain exactly what we're about to do to our patient. As we transport patients with visual impairments, what kind of things do they need to take with them? Do they have a walker? Do they use a cane? Do they have a guide animal, a guide dog that we need to, a service animal, that we need to take with them? And we should think about that. Usually in most agencies, it's perfectly permissible for us to bring the service animal with us, and unless it's going to cause further complications, we want to make sure that the animal is there. Now, keep in mind also that the service animals also kind of act as a protection or protector for their human. And sometimes if the patient is unresponsive or unconscious, that patient may go, and that service animal may go into protection mode. So we need to be aware of that. I've had patients who have been both visually impaired and hearing impaired, and I think sometimes the hearing impaired is a little more challenging for us to take care of. They can see, but it's hard to communicate. So don't assume that just because a person can't hear, and again, there's varying degrees of hearing impaired. Some people function very well with hearing aids and other devices to help them to hear. Others cannot. But don't assume that just because somebody is hearing impaired that they can read lips or that they understand what you're saying. And yelling at them and speaking louder is not going to help at all. Some of the challenges, as I mentioned already, is communication with our patient who is hearing impaired. So look at the patient face to face, and then ask them the best way to communicate. And maybe we have to write that down on a notepad. What's the best way to talk? If you know sign language and the patient knows sign language, that's amazing. Then you can communicate with our patients. But not many of us know how to sign. So there are some. Your book had some simple signs that we could ask. You know, if the patient was in pain, if they were ill, and such. But unless you know sign, find out what the best way to communicate. As we said, you know, don't speak louder. Try lowering the pitch of your voice. ASL can be useful, wonderful if you know how to do it. If you can speak it, that's amazing. The first illustration there is, are you ill? The second one is, where's the pain? And then I can't remember what the third one is. Some patients use hearing aids, and there's several types available. Some go in the canal, ear canal. Some are almost you can't see them. Invisible ear, you've probably heard that. The device should fit snugly. We want to make sure that we bring it with us, even in the presence of trauma. You know, bring it with us for the patient later on, even if we're not seeing the need or there's injury to the ear at this at this point when we see the patient. We want to make sure that we bring that hearing aid with them. Here's an illustration of some different hearing aids. The one in the center here with the cable, not as common as they used to be, but that was kind of like, you know, the old school hearing aid. And then there were some that were like bone oscillating, and that's an example of one where it had the thing in the ear, and then it also had a thing that went on the skull, and when the sound waves would come in and hit the receiver, it would kind of oscillate the bone. And then I had a friend in high school who had one of those. And then again, some various different types of hearing aids. And sometimes it's as simple as the batteries are worn down. Hearing aids have come so far in their technology now. They're rechargeable. They're just amazing. Almost invisible. Like I said, you've probably seen the commercials for the invisible ear and such. So look for the little plastic antenna looking thing sticking out of the ear in case the patient might have one. Again, with all of our patients, we want to make sure that we treat them with dignity and respect. Cerebral palsy is another common disorder that we will see amongst many of our patients. And as it says here on the slide, it's a group of disorders characterized by poorly controlled body movement. In other words, they have no control over some of their muscles, their functions. So some things we need to look at is make sure that they're breathing. So look at their airway. Some cerebral palsy patients, depending on how long they've been suffering from this, may be on ventilators. So they might have a ventilator that's attached to them, or if they're in a wheelchair, they might have it somewhere on the wheelchair. But don't assume that just because the person is physically disabled, that they were also intellectually disabled. Remember, Stephen Hawking, one of the most brilliant people that's ever lived, suffered from cerebral palsy. So truly, no intellectual stunting or disability with that man. Sometimes the limbs are small. They have an unsteady gait. And they might contract into different positions that would for you and I seem to be abnormal. Never force them into a position that it won't easily move into their extremities. And if we are transporting a patient with CP, make sure that we bring their devices with them so that they can ambulate. That's always important. And if needed, maybe if they won't fit in the ambulance, some of these power chairs are pretty big. They might not fit. We might have to call out, other transportation or battalion rig or something to transport them. But whenever possible, try to take their devices with them that allow them mobility. Spina bifida is a birth defect, whereas you can see that it's an incomplete closure of the spinal column, and part of the spinal cord can be protruding from the patient. I have to honestly say I have never seen this in my career, and it can be surgically repaired from what I understand, but it can cause some damage along the way. So some of the things that we might see with a spina bifida patient is hydrocephalus, so swelling of the brain. They could have paralysis in their lower extremities. Maybe they don't have control over their bladder or bowels. And they seem to, and I was looking at this, and I'm not sure why, but they seem to have a lot of allergies, but particularly to latex. And it's fortunate that we don't have pretty much nothing anymore in the medical community as far as PPE and stuff that we use has latex in it, which is good. We're going to see several patients who suffer from paralysis. And again, we're not sure. Some of the times we will know the cause, and some of the times we don't. Some have partial feeling or partial movement, and others are completely paralyzed. But we know that paralysis, by definition, is the inability to move parts of the body. And they may have some sensation or they may not have any. If their diaphragm, remember if they have damage to C3, 4, and 5 of the cranial nerves as they come down and innervate with the 4th, 5th, and 6th vertebrae, and there could be damage there. Remember that that is the nerve bundle that drives the diaphragm. So if the diaphragm isn't working correctly, then our patient might be on a ventilator. And when we have patients on ventilator for long term, and this goes back to our cerebral palsy patients also, look for the ventilator to be in a tracheostomy or in a stoma. So lower down so that it's not hanging out of their mouth, but it's actually did like a tracheostomy or a stoma, and they intubated that. Some of our paralysis patients may require suctioning, and sometimes we get called out for people who are paralyzed from various disorders. We used to see a gentleman who had Lou Gehrig's disease, or ALS, amyotrophic lateral sclerosis. And it's a disorder that causes complete and total muscle failure. One of those muscles, of course, being the diaphragm, and required suction. So look for additional tubes and equipment that the patient might have. They have catheters, colostomy tubes, feeding tubes, etc. And make sure that when we're checking and we're taking care of the patient, that we are aware of those devices, so that we don't accidentally remove, for example, a catheter, a urinary catheter, by moving the patient, and we didn't see it and we pulled it out. That could be very uncomfortable for our patient. So, and then ask the patient if they know the best way to move them. Ask the caregivers, and use every available resource that we have on scene to effectively move our patients. So bariatric patients, or obesity, is a pretty serious disorder that we see. Some people think it's just a U.S. thing, but it's really not. It's kind of a lot of places. 30%, obese is somebody who's ideally 30% over their ideal body weight. So by definition, look around, consider some of the people you know, and I fall into this category myself, by definition. Severe obesity is 2 to 3 times over their ideal weight, and these are people that we see a lot. And what are the causes? Don't. This is again where we as healthcare providers, as EMS providers, need not to get judgmental, and it's sometimes very hard. We as healthcare providers do our best to stay healthy and such, and don't assume that just because somebody's obese that they're not healthy, that they don't take care of themselves, or they don't work out, or they just eat a lot. This is, as it says, can be attributed to a low metabolic rate. It truly can be a glandular problem. If their thyroid is not working correctly, no matter what they do, they will not lose weight. There's also a syndrome called Pickwickian syndrome, where the patient, no matter what they do, their body just metabolizes things into adipose, into fat, and it can be bad. So when we interact with our patients, just like everybody else, be nice. Above all, be nice. Treat them with dignity and respect. But think about that we might need more people. Do we have a vehicle, a bariatric ambulance, that is designed to help transport some of our patients that are, as I call them, plus size? What resources are available to us? In Kitsap County, there's really limited resources. Olympic Ambulance has a specially designed ambulance set up to transport bariatric patients. They have ramps and a winch, a larger gurney to help move the patient. But if it's so if that's something that we can do, if it's available, call them. Try to make it as comfortable for the patient as possible. And again, I cannot stress this enough. Do not judge. Be nice. Show respect and dignity for our patient. Avoid trying to lift the patient by one limb or another limb. Whenever possible, get enough people. If you have to, call more people so that we can move our patients. And then all of our movements should always be coordinated. Look for pinch points with our patients. Pressure from maybe they're sedentary because of their size. They can't get up. They can't move around a lot. They can have significant health issues such as DVT, deep vein thrombosis. So make sure that we're taking care not to complicate their situation at all. Sometimes they have trouble breathing. They can't lie flat. They have a lot of extra weight that lays on their organs. And so what's the best way to move them? And what do they sleep? So ask the patient this. As with all of our patients, have a plan before we move them out of the house. What's the best way? Do we have enough people? Do we need that special ambulance to transport the patient? And then we arrive at the hospital during our short report. It's good that we inform the patient or the hospital that we have somebody who is obese and that may require special care. Many of the facilities have special lifting devices, extra wide beds, etc., to help facilitate our patients' needs. So we talked about some disorders that could lead to the possibility of patients having tracheostomy tubes, such as cerebral palsy, head injuries, trauma patients, etc. Long-term care. Because people are going home with these disorders, we're going to see patients who have these devices implanted in them. So as you can see here, this is like a special endotracheal tube that is very small that goes into where we would to a stoma in their trachea, and so it'll be on their neck somewhere, and we'll see that. Sometimes they can get dislodged, and other times they can get filled up with gunk, so they might require suctioning. So, again, ask the patient's caregiver what the best way to take care of that, and remove some of those devices or stuff. So remember the dope pneumonic causes of obstruction. So displaced or dislodged, obstructed tube with secretions or mucus, the pneumothorax, or equipment failure. So look for those things as a cause for problems with the patient who might have trouble with their tracheostomy tube. And again, ask the caregiver and find out how they best manage the patient. We're going to see patients who have mechanical ventilators. Sometimes we get called out there. This typically, at least the transport or taking care of them, might be considered ALS in some systems. But again, find your local protocols. If the patient's ventilator is not working correctly and they're have a tracheostomy tube in place with the collars, such as in the last slide, then take your bag valve mask, put it on the tube itself, take the mask off, put it on the tube, remember, like on the eye gel, right? And then ventilate the patient just as you would if you were ventilating with a bag valve mask through an eye gel. Transport, call ALS if necessary. We are not typically trained in how to fix ventilators. That is, the ventilator tech needs to come out and take a look at it, but we can take them, we can breathe for them with a bag valve mask, and we can take the patient to the hospital. There are other devices such as apnea monitors used for premature infants. Some of them might have severe gastrointestinal reflux or GERD, and it can cause apnea. The acid builds up and goes up into the patient's airway. It can cause problems. Or if the patient has experienced a life-threatening event, and we talked about that in the pediatric class, where they came to a near-death type of an experience, and then they resolved it, or they had the patient has a history, or the family has a history of SIDS, they might be have apnea monitors so that we can monitor them and see if they become apneic. So they do it from 2 weeks to 2 months, kind of depends on what the doctor wants. They take them home. It's kind of like trying to think of, I can't remember what they look like, but somehow they're attached to the patient so they can find out if they're apneic or not breathing. We have patients, many patients who have internal cardiac defibrillators, ICDs or ICPs we call them, or pacemakers. They're just under the skin. They're about the size of a 50-cent piece, usually located in just under the left collarbone, but that doesn't mean that that's where they always are. Some of them can defibrillate. Some of them can are just pacemakers. AICDs, internal automatic cardiac automatic defibrillators, AICD, automated cardiac defibrillators that are anyway, they're planted under the skin and they can defibrillate the patient. If the patient's defibrillator has been shocking them, their internal defibrillator, this truly we need to have ALS intervention, or they need to get to the hospital as quickly as possible. Never assume that it's malfunctioning. The chances are it may be working correctly. And then every so often, I think like every other week or every 2 weeks, I'm not really sure exactly, but especially after they first get a pacemaker, they will have to do what is called interrogate the pacemaker. They'll call a phone number. They'll put the phone up next to the pacemaker, a series of beeps and buzzes and whatever, and it will access the computer inside the pacemaker. Then the doctor can make adjustments over the phone to that pacemaker. Isn't technology amazing? So LVADs, left ventricular assist devices. We do have a few patients in Central Kitsap who have this. This is quite an interesting device, actually. It's worn like a vest, and it goes into the heart, into the left ventricle. They bore a hole in the left ventricle, and it's a pump that actually moves blood around inside of the heart. The crazy thing is, when you check the patient's pulse, they don't have one because their heart is not beating. The LVAD is doing all of the work. So again, rely on the caregivers. The biggest problem with the LVAD is the battery. So that often might be the problem. The batteries are getting low. So start there, start easy, work hard. There's always a number. The patient will always have a number on the vest that they wear with the batteries that you can call to get more information about how that, and then transport them if there's a problem. And it is possible. What I just read recently in a class I went to do CPR on a person whose LVAD is not working and they're unconscious. it would be working, but we can do CPR. External defibrillator vests, not as common as as the internal defibrillator, but this might be a patient who has to have this external vest. They wear it like a vest that they're waiting for a pacemaker or a defibrillator to be installed. I honestly have never seen one of these in my career. We will see patients with central venous catheters, usually coming out of the right side of their chest, just below the collarbone. They might have a couple of ports coming out. For us, it's really important that we don't mess with it. It goes right into the subclavian, and then into the superior vena cava, and then right into the right atria. So if they get dislodged, control bleeding. They probably bleed a lot. Common problems that they have are that they get infected. They can get infected. So there's different types. There's these little ports that are underneath the skin. They have a little bump, and you'll actually see like maybe the hose, the tubing underneath the skin. And then they also have what's called Hickman catheters that come out that have like 3 ports on them, and then there's a couple other catheters that come out, and those are all central lines or central venous catheters. And here's an illustration of one. Sometimes they're used for patients who are on dialysis, and maybe they're just going to be on dialysis temporarily because of a disorder they have, or they're doing some treatment, or they put them on this before they get their shunt placed in their arm. But one of the other things that we want to keep in mind that a lot of the patients who have these, they have them because they either have poor vascular access and they need to get treatment often, like patients who suffer from cancer, who are getting chemotherapy treatments, other disorders such as multiple sclerosis can have infusion treatments, and patients might have these central lines. We'll see patients, especially patients who have suffered from other debilitating injuries or disorders, TBI, head trauma that's causing problems in the contractures that are happening, and the muscles aren't working right, and they can't move food around. They'll have what's a gastrostomy tube, or a G tube, we call it. And they'll be implanted into the stomach, usually into the small intestine. So it might be an ilia into the ileum or to the jejunum, but they're designed for nourishment. We will see them sometimes when they get plugged up, or they get pulled out accidentally. And if that's the case, it's a wound. Dress it and transport it to the hospital. Don't try to put it back in. Let the doctor do that. Some of them need to be surgically implanted. There's an example of one there. There are shunts that are placed in the brain into the ventricles, and you might feel it that runs down the side of the neck, and then it'll drain into the abdominal cavity. And these are they go into the peritoneal space, and then the patient can help balance his cerebral spinal fluid. Sometimes one of the things that happens with these also is they can get infected, they can get plugged up. For us, look for altered mental status, look for respiratory arrest, and the knowledge that the patient has a shunt is important that we pass on to the hospital. and then we protect their ABCs and manage their airway, breathing, circulation, and transport them to the hospital. So vagus nerve stimulation, that's somebody coughs and they pass out, or they're bearing down on the toilet and they pass out. The vagus nerve innervates near the heart and the stomach, and kind of, so it is there to prevent seizure activity and such like that. Um, but some people who have, are stimulated really quickly or easily, um, can can have problems where they pass out a lot. And again, this is just, we're not going to do much other than it's good to know information to pass on to the hospital. We will see patients with colostomies, ileostomies, and urostomies. Also nephrostomies, which is a urostomy that goes right into the kidney. And it's important they'll have a bag that collects their fecal matter or their intestinal products of waste, either urine or fecal matter. So make sure they're aware of it. Patients with recent abdominal surgeries, they can have temporary ones, cancer, they can have permanent ones, parts of their bowels have been removed, etc. Most patients who have them take care of them pretty well, but it's an orifice that isn't where we're supposed to have one, so it can get infected. So we got to make sure that it's clean and it's been taken care of. So it's really important when we're taking care of patients with special considerations that we always involve the caregiver. That caregiver knows so much more about the patient than we will ever know. They will know everything there is to know about their devices, their medications, what treatments they've been having. So make sure we use them as a resource. Don't come in with this, I'm an EMT, I know what I'm doing, I'm here to help. Use them, rely on them. So one of the things we want to ask the patient or the caregiver is, what is different today? Because clearly they've been taking care of this patient for some time. So what has changed? And what can we do and how can we help the best for our patient? We will see numerous patients who are on home health and home care, from infants to developmental disabilities. We have numerous respite care facilities scattered throughout Kitsap County, and no doubt other counties have similar things. Some of these care facilities specialize in patients with significant intellectual developmental problems or cerebral palsy, and some are just helping take care of the older patient that doesn't qualify necessarily for a skilled nursing facility, but is overwhelming to the family. So there's a variety of them throughout our area. Do the best we can to, again, get information from the staff, the caregivers, and how can we best help the patient. Hospice care, first of all, these people who work in hospice and palliative care are amazing. They are such wonderful caregivers. I got to interact with them personally when my sister was going through her cancer, and they are just amazing. Um, Different levels, of course. Hospice, their goal is to make the patient comfortable and allow the illness to run its course to termination. and they respect the DNR, do not resuscitate orders. Sometimes we get called to go out there with a hospice patient. Our job at that point is to interact with the staff, find out what their needs are, and maybe to just verify that the patient has died. We're not going to attempt resuscitation. We're not going to get in their way. That's not our job. They are wonderful. And then the palliative care, they provide them with medications, pain, help them control things. It's kind of the step before hospice. And they're amazing also. So find out what our local protocols, what your local protocols are, wherever you're going to be in our interaction, who we need to notify should we respond on a hospice patient, what hospice service the patient is on, and what the patient's wishes are. And show compassion. Be nice. Be sensitive. Sometimes we get called by the family for a patient who's in hospice because they're not prepared. They think they're prepared for their loved one dying, but when it actually happens, they're terrified and they're scared. So they call 911. Comfort the family. Be professional. Contact the hospice service if that is your protocol. Poverty and homeless. We see a lot of homeless people in our area, and we've probably seen some of the documentaries on homeless in Seattle and King County and around Kitsap County and such. There's been some, and it's been classed as a problem or whatever it might be. I'm just going to give you a quick hard fact. In 2019, 567,715 people in the United States were homeless. That's really, when you think about it, it's only like 0.2% of the entire population of the United States. But when you look at it as that number, that's like Tacoma, the city of Tacoma, with 567,000. It's more like Seattle being homeless. It's 500,000 people that are homeless in the U.S. The problems that we encounter with people who are homeless is that they lack the basic needs that care for themselves. Sometimes this homelessness is caused by poverty. They don't have money. Sometimes it's caused by they don't have enough money. Many people who are homeless have jobs. I mean, like real jobs. Like they go to work, they shower, they do their job, they come home, and they live in a homeless community because they can't afford to live anywhere else. Some of the homeless population suffer from mental illness, or maybe they've had a brain injury. Maybe they were injured, they're wounded combat soldiers or service people who came back with an injury. Maybe they're addicts. Who knows? Again, don't judge. That's not our job. Our job instead is to be the advocate for the patient, for all of the patients. No matter how many times we've seen this homeless person, no matter how many times we have taken care of them, our job is to be the advocate, to make sure that they get the best care possible for them, regardless of their ability to pay. It's not our job to find out if they can pay for the ambulance ride or the services that they're going to get. Our job is to take care of patients and to provide the best care that we can while we're there. One of the things that we can do in taking care of the patient, is when we get to the hospital, find out what social services are available and how that works in your community. We are going to see people who are homeless. I can't tell you if it's going to increase or decrease because nobody knows that. I can tell you that as an EMS provider, no matter what system you work in, no matter what community, no matter how affluent that community appears to be on the outside, there are people who are homeless in that community. Treat them with kindness, with respect, and with dignity.